morning, everybody, and I would like to thank AIOS for this opportunity.
Please speak in the mic, yeah.
I have been given the topic of Beyond the Obvious White, Preoperative Evaluation of White Cataracts. The preoperative evaluation of white cataracts is like looking at the tip of the iceberg, because the white cataracts are a heterogeneous group of cataracts. All of them may look white, but if you look at each picture in this slide, each cataract is going to have a different set of challenges intraoperatively. So how do we evaluate these cataracts? In white cataracts, what is the risk? We are uncertain about the posterior segment. There are biometry challenges. Pupil issues and zonular issues are more. The red reflex is obscured. Many of the white cataracts have high intralenticular pressure, and the endothelium is at a risk because most of them are going to be hard or suprahard. So how do we assess them preoperatively? We have to assess the posterior segment so that we can have a prognostic indicator. Biometry challenges are there. And then we have to correlate our slit lamp examination with the ASOCT findings, and then correlate what and anticipate how we are going to face the surgical challenges. So now first is we have to check the visual acuity, that perception of light and projection of rays is accurate or not, and always examine these patients undilated so that a relative afferent pupillary defect is not missed. And on dilatation, look at the pupil, if it is adequately dilating or not. A non-dilating pupil with a hard cataract, shrunken posterior capsule, these are the cataracts in which you are going to have high chances of zonulopathies. Now you can see in this video, in an undilated cataract, undilated pupil, you can see that there is gross phacodonosis. So it's very important to see undilated pupil, not to miss out any zonular weakness. This is the checklist. Do a B scan. The endothelial cell count is important. And then what are the biometry challenges? Optical biometry failures are high in these cases. So we need to use immersion biometry for calculating the axial length. And when we are planning premium lenses or toric lenses, it is very important to have a very good ocular surface. You can repeat your biometry readings and check so that we are able to have good post-operative refractive outcomes. Now we'll see a few cases and then just discuss what challenges can be there intraoperatively. Now if we get such a type of mature cataract, you can see that there are cortical clefts are there in which there is cortical fluid. Even on the slit lamp, on the slit you can see these cortical clefts filled with fluid are there. On the on the biometry, we can see that the anterior chamber depth is shallow. Even if you look closely at the scan, you can see that a fluid is seen here itself in the just in the anterior, inside the anterior capsule. So in such cases, what we can do is we can plan a small capsulorhexis, so that that area of from that area we can just aspirate the cortical fluid, so that, and then later on we can increase the size of the capsulorhexis. So that will make things better for us. Now look at this cataract. When such a white cataract comes to us, what we have in mind is it is a very intumescent cataract, AC depth is shallow, and such cataracts are going to have a very high intralenticular pressure, which is going to make capsulorhexis challenging. Though the nucleus looks soft, we can see on biometry that the AC depth is shallow. On ASOCT, we can see that there are fluid-filled cortical clefts which are seen just beneath the anterior capsule. So we have to be ready to deal with the dreaded Argentinian flag sign. So these are the cataracts in which if we start the capsulorhexis right at the center, there is high risk that such a Argentinian flag sign can develop. So what things we can do to prevent the Argentinian flag sign? I will just mention a few things that we can do. A needle aspiration, we can take a 30 gauge needle and in a closed chamber go right inside the anterior capsule, and while we are puncturing the anterior capsule, start aspirating it so that the intralenticular pressure is reduced. This is a animation showing it. But in spite of doing all these things, starting in the center and starting a small capsulorhexis, there is a chance that such kind of cataracts can have extension of the capsulorhexis. So if this thing happens, what can we do? Here we can utilize the flap motility sign to our advantage as published by Dr. Rohit Om Prakash sir. If the flap is everted and it is freely mobile during the phacoemulsification, we can be sure that this capsulorhexis tear has not gone to the periphery, and using all the lower fluidics, lower parameters, we can continue with phaco. Now this is the third case. Now such a white cataract coming to us in the OPD, this is a typical Morgagnian cataract. So what should we have in mind while doing the surgery? This is a liquefied cortex is there, and the nucleus, a dense nucleus sunken in the liquefied cortex. There is absence of epinuclear or cortical cushion, and calcifications are seen over the anterior capsule. So we have to anticipate zonulopathy and dealing with a moderately dense nucleus. Now, this is the third case. This looks like a routine mature cataract. The AC depth is also okay and pupillary dilatation is good. So one would not expect, one would consider it as a low risk in terms of mature cataracts. But when we have a look at the other eye, there's a monster staring at us. It is a typical PPC in the other eye. So always have a look at the other eye, so that otherwise you would have missed out many things while doing these cases. So we have to plan a surgery like we are planning a posterior polar cataract. ASOCT will definitely help in these cases. So we have to do the risk analysis, hypermature cataracts, zonular
Dr.
dialysis.
Trupti, please sum up.
Yes. So just evaluate, anticipate, and strategize. Thank you, sir.
Thank you, Dr. Trupti. Dr. Kiranji. Yeah.
Dr. Shruti, you did not show the video of the last case in which the monster was looking straight at you. We'd love to see that video. And I just want to tell everything, something about the white cataract, a hypermature, swollen, intumescent. It is a misunderstood cataract and wrongly dealt cataract. Normally when the split happens, we look at the capsule and say, you have dished us and you have torn into two pieces, you are very bad. All the suspicion goes on the interior capsule, but the real fault lies with the forward movement of the nucleus and the cortex forwards. So you must have gone to some malls with the children and made your children jump on a trampoline. If your child jumps on the trampoline in the center, he will go much higher as compared to jumping in the periphery. So there is pressure from behind which is maximum at the center. So it is a wrong concept to touch the interior capsule in the center, to start a primary axis in the center. And we have published a paper in which we do a primary axis in the mid periphery. And it is very safe because the nucleus will not come forwards, because its forward movement will be checked by the intact central part of the interior capsule. It will not come forwards. After making a small primary axis in the mid periphery, you can aspirate in all the quadrants with a cannula and with a dry aspiration, not the irrigation one. Because if you concurrently you do irrigation also, You may be pulling out soft lens matter, but you will be sending in that fluid which is not visible to your eye, but that is adding to the entumescence again. So do a dry aspiration after you have flattened the interior capsule, then give 2 nicks and go around the interior capsule. You will never have a Argentinian flag. This is what I wanted to say.
So thank you, Dr.
Thank you,
Kiranjit.
sir.
Thank you, Dr.